So, as a medical physicist, I have to speak to you about those descriptors, organ at risk, radiation dose, and diagnostic reference levels. So, let's start with the main dose descriptor in CT. We have the volumetric CTDI. This is a local dose descriptor, and it's the average dose, or represents the average dose over each slide. It is the dose measured in an acrylic phantom of 32 centimeter diameter for the body with a clinical protocol. For this reason, it's not patient dose. It's useful for measuring measuring tube output for comparing CT protocols or for diagnostic reference levels. The second dose descriptor is dose length product. It represents integrated dose over the whole scanned area. It's the product of the CTDI vol and the scan length. Again, it's not patient dose, it's per centimeter, and it can be some scan examinations. DLP is useful for diagnostic reference level and also for estimating effective dose. The first rule in dose reduction is to look at the CTDI vol and reduce the scan length to fit the anatomical region to the clinical indication. And these two dose descriptors are not enough if we want to speak about radiation risk. For speaking about radiation risk, we have to investigate organ dose and effective dose. Effective dose is the sum of the tissue equivalent doses weighted by the ECRP organ tissue weighting factors, which takes into account the varying sensitivity of different organs and tissues to radiation. Organ and effective dose unit is millisievert, and effective dose can be seen as the effort to equate the partial body exposure of diagnostic X-ray to a whole body equivalent stochastic risk. That means cancer effects induced by radiations. Remember also that radiation risk is gender dependent, and radiation risk depends on the age at time of exposure. This is because it's higher for children and young people with a longer expectancy lifetime. And here we can see the main organ at risk involved in a chest CT, which are breast, lung, and thyroid. Breast is considered one of the most radiosensitive organs in the body, and it has a weighting tissue factors of 0.12. It's superficially located and can receive a relative high radiation dose in CT when no dose reduction system are used. And it presents a higher risk for women. Lung is, of course, the main organ in chest and has the same radiosensitivity as breast. And then we have thyroid, a little less radiosensitive than the other two, and take care that it can be partially or completely included in the scan region. And so, again, the choice of the scan region is very important, and we should take care in each. So we said effective dose is the sum of organ dose, each one weighted with is a special factor, and they are summed together to give the whole body effective dose. And effective dose is related to the stochastic effects and stochastic risk. This may be the cancer induction due to radiation, also potentially at low doses, while organ doses are related to the so-called deterministic effects which take place only when a threshold dose is surpassed. Normally, this doesn't happen in a normal CT scan examination. Effective dose is not directly measurable in vivo, but we can only estimate it. An easy way for a rough estimate is to take the total DLP from the dose report and multiply it with the region-specific coefficient factor. In this case, here is reported the chest factor. Pay attention that the display DLP is displayed for each completed acquisition in the dose report, and is typically summed up for all the acquisitions. So you need to take the total DLP. In this case, they are the same because this is an example with a single scan acquisition. Okay. A more accurate way to estimate effective dose is to use mathematical phantoms and Monte Carlo. Now, the widespread of the dose tracking software help us in this because they just used these methods, and in this way we can have a more accurate estimate. Of course, all this software should be previously validated. And we have already heard in the previous presentation that for the same anatomical region, we can have different clinical indication, and the right approach is to choose for each indication the right scan protocol. This means the number of scan phases, the scan range for each phase, scan parameters for each phase, dose adjustment based on patient size, dose reduction tools like automatic two-current modulation, KV settings, iterative reconstruction, and others. Afterwards, we'll tell you something about this. And different scan protocol mean, of course, unfortunately, often it happens in the clinical routine that we have different scan protocol also for the same clinical indications. I've already found on our CT scanner protocol with a person name or surname like Chest Piero, Low Dose Dr. Rossi, and so on. This is not so good. And now, how can we compare those in chest CT? This can be done using diagnostic reference. Remember that these are dose levels for typical examination for groups of standard-sized patients. Typically, the 75th percentile of observed doses from local, regional, or national surveys, and that most DRLs have been established based on anatomical region and for a single scan. And so in 2017, ECRP suggests that DRLs should be defined for clinical indications instead of anatomical region. So DRLs are a practical tool for those comparison and optimization. I will start showing you the Italian DRLs published in 2014, but as far as I know, are still the most recent DRLs in CT for my nation. Data have been collected from 67 scanners and more than 1,000 examination and around 2,000 acquisition. And data were also collected following the clinical indication in case of chest, vascular infection, and cancer diagnosis and staging. Here I reported the DRL for the CT-DI-vol of 15 milligray and DLP, and also the total DLP. It's important to collect the total DLP because the total DLP gives us information about the whole examination, and we can see that more than 30% of the chest examination were performed with more than a phase, more than a scan, 1, 2, 3, and also 4 scan for a CT examination. And you see that every phase let's dose increase considerably. In the study, we found also large interscanner variation and large protocol variation, and the high variability between scanning parameters. Q voltage rarely was less than 120 kV, pitch rarely different than 1, and PMI almost not collected. And now let's come to an European study. In August 2017, the European Commission launched the Euclid project led by the European Society of Radiology with aim to establish DRL based again on clinical indication. A review of the literature from 15 countries was conducted. 12 of these countries were European one. And here we can see the results concerning chest CT, except the cardiac application. And here I reported the variation in CT-DI-vol and in DLP for this different clinical indication. And you see that, for example, for interstitial lung disease, we have also 2 different protocols, axial and helical. It is not always easy to compare data, and sometimes it was not well specified also if this DLP were a single or for a multi-scan acquisition. And now another interesting publication in 2017 for 10 different adult CT examination, this time as a function of patient size. The CT-DI-vol mean and third quartile, as well value and DRL. We see that in common chest, the CTDA value and DLP are similar, a little bit higher for chest and pulmonary arteries. But the very interesting thing in this study is that they show us also another descriptor, the site-specific dose estimate. This was introduced by the AAPM and was initially thought only for pediatric patients, but SSCDA is important also in adult because it takes into account the real dimension of the patients taken from the SCOUT and defines correction factors to be applied to the CTDA-VOL in order to obtain more realistic doses. You see, CTDA-VOL is multiplied by these correction factors. And we can see just in this slide that SSDA is the mean value is higher than the CTDI-VOL. And also, if the data are not shown in this slide, for smaller patients, SSDA is higher than CTDI-VOL. This means that when we are looking at the CTDI-VOL, we are, of course, underestimating the real dose. And this is critical in a smaller patient. It is a little bit lower for larger patients, but this is not so terrible. Again, a comparison as was just presented before, and the difference between a standard and a low-dose protocol. A normal dose protocol, we can have CTDA-VOL, this is an example, around 14 milligram and an effective dose around 10 millisievert, while in a low-dose protocol for screening lung cancer, for example, we can achieve 1/10 of the dose. Why is this possible? This is possible because we have lungs, and air causes less X-ray attenuation, and so requires air results in higher inherent tissue contrast than most lesions, and so can be imaged at lower doses. And then the presence in the chest of heart, large blood vessels, this means that pulsating structures require faster scanning, and so dose reduction, and also short scan duration, which reduces respiratory motion artifacts, and the presence of high contrast offers. And here I would like to show you the results of a lung cancer screening trial we performed, a retrospectively non-randomized observational study. And the objective of the study was to estimate the cumulative radiation exposure and lifetime attributable risk of cancer incidence associated with lung cancer screening using annual low-dose CT. And we have analyzed and we have estimated the organ dose and effective dose in more than 5,000 asymptomatic high-risk participants who underwent a low-dose CT for 10 consecutive years. And the main results was median cumulative effective dose after 10 years of low-dose CT screening, around 9 millisievert for men and 13 millisievert for women. So let's say it's the equivalent for men of a conventional chest CT and an abdomen pelvis CT for women. Or we can also say less than 10 years of background exposure to natural radiation. Concerning lifetime attributable risk for lung cancer, theoretical lung cancer induction, we see that in women it's threefold higher than in men, also taking in consideration the years, because I said it depends on the age, and also the life attributable risk of major cancer is fourfold greater in women than in men. So be always aware when scanning women, even with low dose in chest CT, because of their greater radio sensitivity and their higher breast cancer risk. And then last, I would like to show you a BMI tailored protocol, which we have proposed at our institute. We have trained radiographers to choose between 3 different CT protocols with 3 different KV, not only, but the main differences are KV for small, medium, large, and with 3 different BMI. And the results are here reported in these tables, and we have seen that in 73% of the women we could spare 36% of those. And in men, 25% in 55% of all the men. You see that a dose increase in large patient, but you see that our protocol is for very large patient, as a BMI greater than 36 are normally obese one. So KV reduction reduces considerably dose and improves also contrast, and therefore we suggest that 140 kV should almost never be used. Almost always use 100 kV and 120 kV only sometimes. And so my last slide, what we should be aware of, look at the CTDI and reduce scan lengths to fit the anatomical region to the clinical indication. This is very important. Then you have to reduce the number of scan repetitions to reduce total DLP. Each repetition doubles the dose. Choose different scan protocol for different clinical indication. Use DRLS for dose comparison and optimization. Remember always the women has greater sensitivity and breast cancer risk is higher. BMI tailored protocol can considerably save dose, and adopt all dose reduction tools available on your scanner. On this topic we'll speak now the radiographers fair. Thank you very much for your attention.